Okay, so I have two cases, and Steve, I don't want to stand in front of them for lunch, so maybe we'll get through one and take it from there. Okay, all right. So hopefully I had an interesting AS case and then an MR case if we have time after that, but I'll just show you some of the things we're doing here at Methodist. So this is a case, a 58-year-old male with increasing shortness of breath over the past 8 to 9 months. He's unable to, walk more than a block or two now before he becomes a dyspneic. He used to really enjoy playing golf, but unfortunately has had to give this up because of his shortness of breath. Now he doesn't complain of chest pain. He's not having any syncopal episodes, and really at night he's able to lie flat. So he came in for further evaluation, and here's his transthoracic echo images. And I hope you'll appreciate that, this is definitely an enlarged left ventricle. Function is severely depressed. You can see a very heavily calcified aortic valve. We went and calculate some of his hemodynamics. A lot of this was spoken about earlier in some of the talks. You can see here the short axis view of the aortic valve. And you can see how heavily calcified it is, and you get the impression that there is a little bit of opening, but really can't tell what kind of valve this is. You can see that the contour of the CW jet is rounded. The velocity, despite having a very depressed ejection fraction, this patient is still able to generate a high peak velocity and high mean gradients. And we were able, using the continuity equation, we were able to calculate a valve area of 0.8 centimeters squared. So the next kind of thought process here was, well, this probably at least an intermediate high risk patient, and let's consider him for TAVR. And part of that evaluation, as all of you probably know, is to go ahead and then get a CT scan. And so then I'll just kind of highlight a little bit about what we're able to do with CT. Here are his coronaries. You can see some plaquing in the major coronary arteries, but really no obstructive stenosis. So really this was the cardiomyopathy was not due to coronary disease. Here's just an example of, the study was retrospective, so here you can get an idea, again, just similar to echo, of this global severe ventricular dysfunction. Part of the TAVR planning process is to go ahead and then measure an aortic valve annular perimeter or an area for sizing of your TAVR device. And kind of interesting, if you look closely here, you'll see a shelf of calcium sticking out into the LVOT, similar to what our last presenter also showed. That's kind of important to identify for the interventionalist. But here we were able to get a perimeter of about 77 millimeters. And I think, if some of the interventionalists are here, I think that translates to a core valve of, I think, between 26 and 29 device size. And we can take this a little bit further, and we can actually perimeter for you an aortic valve area and actually look at how the aortic valve is opening. And you saw some very beautiful slides just earlier. And here I hope you can, I showed you up at the top right there, we were able to perimeter an aortic valve area of 0.8. But if you'd look closely here at the short axis view on the bottom right there, what do y'all think of what type of valve this is? I hope you'll appreciate that this looks very much like a bicuspid aortic valve. So that was of great interest because it definitely can change the way you would manage these patients, whether they would even qualify for a TAVR device. So, taking things further, obviously part of the TAVR planning is to know the iliofemorals. We were able to do that as well. Now, take a look at this axial data set. And obviously, it's important to review all the data. And I'm not going to give you the answer, but I'll let it play one more time. And then we'll get a show of hands. Okay. So question is, what did we see? If anybody saw aortic dissection, did anybody see an aortic dissection? No, okay. ASD, how about a coarctation? Okay, maybe. Pulmonary embolism, maybe you guys want to see it again. Okay, we'll come back to it. Let me show you some volume rendered images. Well, this was a great case because, you know, and just showing you, and I'll highlight why I picked this case to show to y'all. This was a patient who had 2 left-sided obstructive lesions. Not only did this patient have severe aortic stenosis, as demonstrated both by echo and the CT, with a valve area less than 1, but it's so important to review. You know, in a patient who was young, who we weren't necessarily able to, you know, it's kind of unusual to see severe aortic stenosis in such a young patient. Very important maybe to consider to go ahead and look at the entire aorta. And in this particular case, it turned out that very nicely that this patient had a concomitant bicuspid aortic valve that would explain the early aortic stenosis. And as you well know, coarctation of the aorta is also associated with bicuspid aortic valves. We can take this a lot further with CT. You know, we can pretty much create a center line through the aorta, make it a straight line. I can, you know, make reference stenosis measurements compared to a normal sized aorta just distal to the coarctation. And here, you know, we were able to establish an area stenosis of almost 72% and a diameter stenosis of 50%. And then we went back and said, hey, you know, what happened with that echo? Where we did, you know, was there some technical difficulty? And, you know, this was, sure enough, this was a difficult to do suprasternal views. You can see you really didn't have good imaging, weren't really able to see the descending aorta. And, you know, if you're not able to see the descending aorta, it's kind of hard to aim your Doppler to where you want to pick up a peak velocity. But main thing I wanted to highlight with this case is young patients, definitely, you know, think about bicuspid valves. Definitely you want to also consider ruling out aortic pathologies. Okay, all right. Thank you very much.
Thank you very much.